Mr. Doe. Hello, my name is Keisha Ridner. I'm a PA student at the University of the Cumberlands. How are you today? I'm just going to step over here and wash my hands real fast. And can you verify your name and your date of birth for me? And I'm just going to check your hospital band for your room number just to compare. Okay, so you're here today for your male exam. Does that sound correct? Okay, so to begin, I will explain every step to you. And I'm just going to make sure that I wear gloves for the entire exam. So I'll make sure that the patient's chest and abdomen were covered, and I would have the patient standing while I'm sitting. I'm going to expose this part. Okay. Now I'll just sit in front of the patient. So we're going to begin with inspection and palpation of the penis. We're going to inspect the skin for lice or nits at the base of the pubic hair. And now I'll inspect the prepuce by retracting it and then replacing it, or I can have the patient do this. This just checks for any cankers or carcinomas. And now I'm going to check the glands in the meatus, looking for any nodules, scars, any ulcerations, any lesions, just any abnormalities that I may see. I'm also looking at the location of the meatus. So now I'm going to palpate the meatus by compressing the glands between my thumb and my index finger. This just opens the meatus. And now I'll palpate the shaft between my first two fingers and my thumb, noting any induration or tenderness, and I could omit in asymptomatic or young patients. So next we're going to inspect the scrotum and the scrotal contents. So I will just lift up the scrotum to view the posterior portion, noting any swelling, lumps, or veins. And I would check the scrotal contour, just looking for a poorly developed scrotum on one or both sides, which could indicate cryptorchidism, or any swelling, which could indicate a hydrocele or an indirect inguinal hernia. So now we're going to palpate the scrotum and the scrotal contents. We're going to locate the epididymis, which is on the superior posterior portion of each testes, and I'm going to palpate with my two fingers and my thumb. I'm just going to compare sides and note any tenderness, lesions, nodules, size, shape, and also consistency. And then I would palpate the spermatic cord from the epididymis up to the superficial inguinal ring. Once again, just looking for any abnormalities. So now we're going to demonstrate transillumination of a mask. So I would just darken the room, and I would shine the light behind the scrotum through the mask. I'll just be looking for transillumination as a red glow, and blood or soft tissue does not transilluminate. So after that, we'd move on to checking for indirect inguinal hernia. So once again, the patient would be standing and I would be sitting. I would place the tip of my index finger at the inferior margin of the scrotum. I'm going to move my finger up toward the inguinal canal and vaginating the scrotum. I'm going to have the patient to bear down, which is a Valsalva maneuver, and I'm going to feel for a bulge that would slide through the inguinal canal. I'm also going to palpate the external inguinal ring. I can do the same thing to the opposite side. And a bulge would indicate an indirect inguinal hernia on either side. So now we're going to palpate for a femoral hernia. I'm going to place my fingers on the anterior thigh, which is the femoral canal. Once again, I'm going to have the patient cough or strain down. I want to feel for any tenderness or any swelling. And a femoral hernia is below the inguinal ligament, more lateral, but never into the scrotum. So after we check for hernias, we're going to do the rectal and the prostate exam. So the patient would stand up and lean their upper body over the exam table. We're going to move this. So we're going to begin with inspection. I'm going to inspect the sacrococcygeal and perianal area for any ulcers, excoriations, lesions, nodules, inflammation, just any abnormalities. And I would have the patient to bear down to note any visible lesions. So now I'm going to move on to palpation. I'm going to lubricate a gloved index finger. going to have the patient bear down, and then I'm going to insert my finger into the rectum at the direction of the umbilicus, noting sphincter tone, and then I'm going to insert my finger into the rectum as far as possible. I'm going to palpate the posterior portion of the rectum, identifying the lateral lobes and the median sulcus. I'm also going to note any induration or tenderness, or any lesions or any nodules that I may feel. And now I'm going to move my finger in a complete clockwise and then counterclockwise position, palpating as much as the rectum as possible. I would have the patient to bear down to try to bring the lesion closer to my finger. And at this point, I could remove my finger, give the patient a tissue to wipe the anus. I would test for occult blood and also note the fecal matter on the gloved finger. And then I would ask the patient and make sure they didn't have any questions regarding the exam.